it's time that you must get worried. Firstly, what is primary amenorrhea? What does it mean by primary amenorrhea? The definition. Amenorrhea, the word amenorrhea means absence of menstruation. There's no menstruation. It's amenorrhea. The word amenorrhea is scientific word for absence of menstruation, but there are several types of absence of menstruation, several types of amenorrheas, and it can be caused by many things. The first amenorrhea that I want to introduce to you is physiological amenorrhea. Physiologically, you don't see period. Those are amenorrhea that happens before puberty. Before a child reaches puberty, she doesn't see periods. That's physiological. After menopause, you must have amenorrhea because after menopause, you don't see periods. During pregnancy, you don't see periods. That's physiological. You shouldn't see periods. During breastfeeding and lactation, early, some women don't see periods because of lactational amenorrhea. That's physiological. But what worries more is amenorrhea that's due to disease, pathological amenorrhea. This is what we are going to concentrate mostly in this webinar, that it's a problem, it's a health problem. Amenorrhea, that's because of a pathology. And amenorrhea can be classified into primary amenorrhea, which means primary amenorrhea is the child who has never seen periods in his life. Primarily, she has never seen periods. Or secondary amenorrhea. Secondary amenorrhea is a girl who has been seeing period and suddenly she doesn't see period, but she's not pregnant. Can be various causes that cause that. It's not a topic for discussion. A topic for discussion tonight is primary amenorrhea. Primary amenorrhea. What does it mean? It means absence of menstruation by the age of 14 years. If a child reaches 14 years without menstruation, that should worry every month. More especially if there are signs of secondary characteristics. What are the signs of secondary characteristics? Secondary sexual characteristics means if she has got breast, if she has got pubic hairs, she has got axillary hairs. If a child has got those things, but is 14 years, hasn't seen periods, probably must be worried. There must be a problem. Or you can define it in another way that if there's no menstruation in a girl over 16 years, irrespective whether she has got secondary characteristics or not, which means this two definitions says that if you want to do a wait and see as a parent, I say maybe she's just late, you shouldn't wait beyond 16 years. Whether she has got secondary sexual characteristics or not, 16 years is the cutoff limit. Any child over 16 without periods, the parents are delaying in seeking help for that child. So in patient with primary amenorrhea, approach for parents should be like this. The history will tell you, when was she born? Is he on any drugs? Has he ever had radiation? What are there other external factors that can cause not to see periods? And it must be taken in for examination. The first examination can be done by the parents himself. You examine the child's genitals and look whether she has got ambiguous genitalia or she's developed normally. Although you are not a medical field, but you can see if things are not abnormal. If you can't see that things are abnormal, seek help. Seek help and let it be examined by an expert and see whether there's something correctable or not. Usually, during examination, they involve radiological investigation, including ultrasound examination, whether she has got a uterus, she has got ovaries or not. These days, because teenage pregnancy is very prevalent, we tend to exclude pregnancy because although it's very rare, it's not uncommon that a child, before she can even menstruate, the first menstruation is preceded by a pregnancy. After excluding that, the first thing that we must exclude is that, is this child not menstruating and the blood doesn't come out? You may find that baby is menstruating inside the uterus, but blood doesn't come out. That condition is called cryptomenorrhea. Cryptomenorrhea is a condition where the uterus is experiencing normal menstruation. The endometrium is shed every month, but the blood cannot exit the body due to some obstruction in the reproductive tract, either in the vagina or in the cervix. There's obstruction of blood. That blood keeps on accumulating there. That condition is called cryptomenorrhea. Cryptomenorrhea means hidden menstruation. Menstruation is hidden. An approach is like this. I already like this flow diagram. If your child has got absent menstruation, you want to ask yourself, is it physiological or pathological? If it's physiological, of course, before puberty, we know that there is no menstruation. That's physiological. A child is not in menopause. These are just the conditions where there is physiological menstruation. She's not pregnant, she's not lactating. Then it's pathological. If it's pathological, if she has seen period before, now she's not seen period, that will classify it as secondary amenorrhea. But if she has never seen period in her life, that's primary amenorrhea. As I said, you must exclude whether is she not shedding endometrium every month, but the blood doesn't come out because of some obstruction in the reproductive tract, which means is it not cryptomenorrhea, or is it true primary amenorrhea due to some condition that some of them are treatable, some are manageable. These are few, but not all causes of amenorrhea. Not only the primary amenorrhea can be caused by genetic condition, problem with the chromosomes, which the child was born with. There can be a problem with in the brain, in part of the brain which is called hypothalamus, which is responsible for releasing hormones, and the pituitary gland, which work hand in hand with the hypothalamus in secreting hormones that regulate the menstruation, or the causes of the secondary amenorrhea are the ones below. But because we're not discussing the secondary amenorrhea, we'll not go deep into that. Primary amenorrhea can be in patients who have got a condition called hypogonadotrophic hypogonadism. You pardon me, it's a lot of scientific terms in this one. I tried my level best trying to make it in pure English. There are no terms that I can use to replace this, but I'll try to explain as much as I can so that everybody can understand. When we say hypergonadotropic hypogonadism, it means the gonadotropin, the hormones that are produced by the pituitary, they are high, but the gonads are not responding. The gonads are the ovaries in this case. They are not responding to those. It's thus they are not secreting gonadal steroids. They are not secreting sex steroids like estrogen and progesterone, or they produce insufficient sex steroids. They can be like that. Or other children can have what you call hypogonadotropic hypogonadism, which it means that condition where the hypothalamus or the pituitary fail to produce enough gonadotropin releasing hormone. There are not enough hormone high up, either in the pituitary gland or in the hypothalamus, to stimulate the ovary to produce the sex steroids. So, or the hormones that are produced by the pituitary, which is follicle stimulating hormone and luteinizing hormone, are not sufficient enough to stimulate the ovary to produce sex steroids, which sex steroids are responsible for menstruation. Or there can be developmental defect in the genital tract. There's some sort of abnormality in the genital tract, which we'll discuss some of them now. Or, as I said, there can be abnormality of the chromosomes, chromosomal patterns. There are some of the chromosomal patterns that we'll discuss now. Or some glands, endocrine glands, like adrenal glands and thyroid gland, can be hypofunctioning. So that can be hyperthyroid or hypothyroid, which can disturb the function of the hypothalamus and the pituitary, thus disturbing ovarian function, and thus the baby is unable to menstruate, like in a patient with cretinism or a patient who has got androgenital syndrome, which is that enzyme, the 21 hydroxylase enzyme, which blocks the functioning of the sex steroids and cause amenorrhea. Or there can be some common metabolic disorder. A simple one of them that I chose is diabetes, diabetic of the young, juvenile diabetes, or type 1 diabetes. If it's not controlled, the child is not going to see menstruation, because diabetes is an endocrine condition. The high blood sugar will cause problems. Or the child can have systemic illness, like most especially illness that causes wasting. If the child is very thin because of illness, either marasmus, kwashiorkor, TB, any weight loss, severe weight loss from hunger or from illness, or severe anemia from, more especially nutritional anemia. If feeding is not very well, the child is anemic, she's not going to menstruate. You need to have a good diet and good metabolic function to menstruate. Or the endometrium itself, the sex steroids might be high, but the endometrium might not be responsive due to some illness. More commonly in children is due to genital TB. A patient who has got TB, which can spread, TB usually we know TB of the lungs. TB can affect any organ in the body. If it affect the uterus and the endometrium, it causes adhesions inside the uterus called intraluminal adhesions and cause a condition called Asherman syndrome. And that a patient's either, if it's severe TB, she doesn't menstruate at all. Or if she does menstruate, it will be hidden menstruation. It will be cryptomenorrhea. So the treatment will treat TB. The secondary amenorrhea, I put it just to make sure that you know what we are not talking about. Secondary amenorrhea, I said, primary amenorrhea, a child has never seen period. In secondary amenorrhea, is defined as lack of menstruation for 3 or more consecutive months in a person who has previously had cycle. If you don't see period for 3 or more months, you should be worried unless you are pregnant. Or can be defined as absence of menstruation for 6 months in a patient who has got irregular cycle. There are some women here or some children there that just by nature they've got irregular cycle. They keep 1 month, menstruate for 2-3 months, skip 1 or 2 months, menstruate for 1 month. She knows that she has got irregular cycle. But if you've got irregular cycle for more than 6 months, should be worried. It might not be reversed. But that will be discussed as a webinar on its own. Lack of period in children is very common in the age where they're supposed to be menstruating. It goes about 50% of children in the reproductive age, they don't see their periods. And mothers just do a wait, the approach is wait and see, or a don't care attitude, which I think here is the duty of a mother, not a father. A father cannot ask, very few fathers will ask children, their girl children, about menstruation, except if the father maybe is like me, a gynecologist. My children know that I'm a gynecologist, I deal with this. So they discuss freely with menstruation with me, but most fathers out there are not expected to discuss menstruation freely with their children. If the child a girl reaches a stage where he's supposed to reproduce, maybe he's engaged or he's married, 20% of people who present in the infertility clinic, the problem is related to lack of period. It's related to primary amenorrhea. Majority of them have never seen period. And this period comes in this way. You know that a child at about the age of 9 and 10 will reach a stage called puberty. During puberty, a child will develop secondary sexual characteristics, like breast part will start developing. She will develop axillary hair. She will develop pubic hairs. She will develop genital changes that prepares her for womanhood before she can menstruate. And for a normal female to undergo normal puberty and menstruate, she must have a normal chromosomal pattern. Chromosomal pattern of a female. Every human being has got 46 chromosomes. Of those 46, 23 are from the father to the sperms, 23 are from the mother. And of those 23, 22 are called autosomes. One is called sex chromosomes, which means every person has got 44 autosomes and 2 sex chromosomes. In a female, the sex chromosomes are called X. They are only X. While in a male, one is X, one is a Y chromosomes. So the chromosomal pattern of a female is 46XX. So for you, a child to develop normal puberty so that it can menstruate, should have a normal chromosome pattern of 46XX, which is in the karyotype. And the hypothalamus, which is in the brain, and the pituitary, and the ovary, They form an axis. They're called hypophyseal pituitary ovarian axis. They must coordinate. The releasing hormone from the hypothalamus must stimulate the anterior pituitary to release the FSH and LH. And this FSH and LH must act on the ovaries to release the sex steroids, which is mostly progesterone and estrogen. If this hypophyseal pituitary ovarian axis is derailed somewhere, the hypothalamus is producing, releasing hormones that stimulate, then the pituitary does not respond very well, then there won't be any stimulation of the ovaries to produce sex steroids, which is estrogen and progesterone, which must prepare the endometrium for implantation. If implantation doesn't occur, the endometrium must bleed. So again, you must have anatomically a patent outflow tract, which means from the uterus, the cervix, the vagina, the hymen downwards, it must be patent. Otherwise, if there's a blockage somewhere else, you're going to have what you call cryptomenorrhea, as I've described, that there can be a hidden menstruation. Of course, the sex steroid, when they stimulate the endometrium, it must respond. It mustn't be unresponsive like that endometrium that I've said. If you've got genital TB, the endometrium is not responsive to sex steroids. This is the flowchart that every physiology student will know, that the hypothalamus is a place where gonadotropin-releasing hormones are produced, which acts on the pituitary, and the pituitary respond by producing LH and FSH, which are gonadotrophins, and then they act on the gonads, which is the ovary, which will release estrogen and progesterone, which will make a negative feedback to the pituitary and hypothalamus to stop producing more. It acts all like there's a complex physiological processes, which, if you want to describe it nicely, is that conditions that can affect the hypothalamus, like chronic illness, TB, malnutrition, chronic tumors, childhood tumors, eating disorders, and even excessive exercise such that a person is wasted. A child who exercises heavily doesn't menstruate because there's hypothalamic depression, which causes that. And chronic stress, a child who is living under stress, maybe from family, from other problems that she has, she will never see the periods. And some tumors of the brains, of course, can cause that. And pituitary gland itself, which is just below the base of the brain in part of the skull, which is called sella tussica, can have tumors that are called prolactinoma. They are called prolactinomas because they produce prolactin. Prolactin is hormones that makes, if a woman is breastfeeding, is because of the prolactin is hormone that makes breast to produce breast milk. Such children or such women who have got children with primary amenorrhea have got prolactinoma. When you express their breast, if it's after puberty, of course, you express their breast, there will be some fluid coming out of there because now milk fluid coming out of there. Of course, thyroid, I've said that both hypothyroidism and hyperthyroidism will disturb menstruation. So childhood hypothyroidism and hyperthyroidism should be detected very early. And it's a treatable condition that if you treat it, you can retain menstruation. Above the kidney, there are some endocrine glands, which is called suprarenal glands or adrenal glands, another name. They can secrete hormones, adrenal hormones, that either causes Cushing disease, which is excessive cortisol production, or Addison disease, which has got its own signs that you can see that the patient loses loss of salt, urinate a lot, or she can have what you call congenital adrenal hyperplasia, which has got craniofacial dysmorphia. You can see a child even on the face that this is not a normal person. Or like any other part in the body, you can have tumors that are secreting hormones that will disturb the hypophyseal pituitary ovarian axis. Or a child can have problem in the ovaries themselves. The commonest is what we call PCOS, Stein-Leventhal syndrome, or polycystic ovary disease. Those three names means one thing. If she has got polycystic ovary syndrome, she will produce a lot of androgens and she will have androgenital syndrome without virilization. Virilization, I mean, she will not have a coarse voice. She might have a little bit of beards, but she will not have male type of anatomic features. If a person has got excessive androgen, she virilizes. She will have beards, she will have coarse voice, she will have muscles like a man. But this with polycystic ovary syndrome, they don't have that. They still look anatomically, phenotypically like females. But if we measure the hormone level, we find that she has got more male hormones than female hormones. Or the ovaries themselves, due to some reasons, either congenital or acquired, can just have some insufficiency. They're not producing enough ova because maybe they've got tumors or cysts or there. Of course, we have said that in the uterus, you can have those intrauterine actineae, which can be caused by infection, usually systemic infection. The worst of them all are two, that TB and bilharzia. If a child has had bilharzia at youth, it might affect the endometrium, and the endometrium does not respond, and she doesn't menstruate. Of course, if there's cryptomenoria, there are two conditions that can cause three: stenosis of the cervix, imperforate hymen, and septum of the vagina, which we will discuss later. The first, that an evaluation of a child who presents with primary amenorrhea, it takes a long time because it's a matter of permutation. You assess this and find that you exclude. You diagnose by exclusion. The first that you do, you look for the hormones. The hormone that's produced by the pituitary, the level, FSH, because we know that FSH, follicle stimulating hormone, is produced by the pituitary in response to hypothalamic stimulation. If the FSH level is high and the child does not menstruate, we blame that because high FSH should stimulate the ovary. If the child does not menstruate, it's the ovaries that are failing to respond to the high FSH. So this will cause about more than 25 to 30% of primary amenorrhea. And then that type, you must look, are we not dealing with the chromosomal problems here? Then you take blood for karyotype, for chromosomal analysis. They analyze the chromosome, whether are they normal. If the follicle stimulating hormone is normal or is low, then we must know that probably the problem is why the child is not menstruating is high up, is in the hypothalamus or in the pituitary. And you measure the hypothalamus and pituitary hormone level, or you do a CAT scan, can do X-ray or the cone-down view of the sella tussica X-ray to see whether there's no pituitary tumor now. Nowadays, because of MRI is more sensitive than CAT scan and X-ray, people go to MRI. The only thing with MRI is that it's costly. So baseline, you start first with the X-ray, and then you can go to CT scan. If you don't see it very well, it's then that you can elevate to magnetic resonance imaging, which is MRI, to exclude any pathology intracranially, any pathology in the hypothalamus or in the brain itself, including the pituitary gland. So, as a recap, physiological amenorrhea, don't expect it in children. Pregnancy can just be at the back of the mind, but you don't expect the child to be pregnant unless there's some child abuse of some sort. So physiological amenorrhea can be found only during pregnancy, lactation, and menopause, or before puberty. But we're talking about here a child who has passed puberty, who we expect her to menstruate. Usually that child, the parent says, is just delayed. She has got constitutional delayed puberty, which is common. Some people have got constitutional delayed puberty. They are delayed. You might find that the mother also will say, I menstruated for the first time at 14. So it runs in families. So if you wait, do not wait beyond 16. And those with constitutional delayed poverty, they'll have other milestones that are delayed. They'll have delayed born age, they'll be short stature, they'll look more child, look younger than their actual age. Because even the bone development and muscle development will be delayed. Then those are delayed, just delayed poverty. You wait and see. You can take a wrist X-ray and see on every bone there are places called ossification joint where the bone is formed. If every bone we expect it to ossify at a certain time, at about 13 years, we expect the wrist to be fully ossified. If we take X-ray, find that the wrist has not yet ossified, the ossification center is still cartilaginous. You know that this is just delayed puberty and delayed menstruation. You can wait, but you don't wait beyond 16 years. And usually it runs in families. You ask the mother, the sister, the other siblings, find that in that family, they menstruate a bit late. They menstruate about 13, 14, 15. But rarely anybody can menstruate after 16 years. So that you diagnose by excluding other things before you can say, this is just a delayed menstruation. And if it's delayed, the chance that she'll menstruate are good. Just wait and see. They're just late developer, those children. They will develop like any other. There's no drug therapy required. There's no treatment required. We just reassure the parents, wait and see. You'll find that the child will be developed normally, and you just reassure the baby. The baby will menstruate at their own time. But if the child is not menstruating and her hormones, the gonadotrophin, the follicle-stimulating hormone, and the luteinizing hormones are normal, we suspect mostly in African population TB. TB might not be TB of the lungs. It might be genital TB, which affect the endometrium. And in rural areas where they bath in rivers and the ponds, bilharzia is very common. Bilharzia doesn't have to be active bilharzia. A history of having bilharzia treated sometimes back can leave sequelae that are going to manifest itself at the time of menarche by the child not menstruating. And for you to make diagnosis of endometrial destruction, either by TB or by bilharzia or other infection, you have to do what you call hysterosalpingogram, because ultrasound is very poor in trying to delineate that. You can't do ultrasound to diagnose that. Or you do hysteroscopy, where you go in and scope in the uterus. That means here we're talking about invasive procedure. And this child, by standard norms, he should be a virgin. So it means you're going to break virginity. Well, for you to do HSG, you've got to go to the cervix. So you'll break the hymen. For you to do hysteroscopy, you'll break the hymen. So it will be artificial breakage of virginity in order to try to make a diagnosis. And with lies, if you find adhesions, you can cut them. They cause lie. If you cut adhesions, it's called lysis of adhesions by means of a scissor or with hysteroscope. And thereafter, you can induce ovulation, menstruation by exogenous estrogen progesterone administration, or you can leave the baby, the ovaries themselves produce their own. In order to avoid the area where you have cut during lysis of adhesion to come together and form adhesions again, you can put a loop there to separate those two walls of the uterus, or you put a catheter there for 10 to 14 days. Then I think provision of estrogen there, it accelerates proliferation of the endometrium and make sure that the child can menstruate easily. This is a picture of genital TB, that it destroys the fallopian tube and destroys the body of the uterus, and the endometrium may just form a scar there. This condition, if found early and treated with vigorously with anti-TB, is reversible and the child can have babies thereafter. But if left to form a lot of scar or scarring uterus, all you can do, you can treat it and menstruation can be restored. But fertility cannot be guaranteed. Can't guarantee fertility in a uterus, in a genitals that have been severely affected by TB. The same as if adhesions And severe adhesions, you lyse them, and after lysing them, you put a loop there, intrauterine contraceptive device, or you put a catheter there. You may bring back normal, regular menstruation. But fertility is another problem which cannot be guaranteed. You're lucky if she can be fertile. This is the picture of hysteroscopic resection of the endometrium in lysis of these adhesions. Thereafter, the catheter will be put. I must stress this because women should look at this. Cryptomenorrhea, hidden menstruation, is very common. Cryptomenorrhea, I said, is a condition which is characterized by the apparent absence of menstruation. It's apparent because it doesn't mean this child doesn't menstruate. She's menstruating, but the blood doesn't come out, which means that's why I call it apparent absence of menstruation. Despite the presence of cyclic sexual bleeding that is concealed, that's hidden due to physical obstruction somewhere along the genital tract. One of the commonest that cause this is imperforate hymen. Hymen does not perforate, it is closed. The whole vagina is closed by a hymen. A hymen should have some hole there. It's either cribriform or one hole or oval hole, different types of shapes. But if it's totally closed, imperforate, the child will menstruate, but blood will be trapped behind the imperforate hymen. And this you can see by that child who experienced cyclic monthly pain early, before it's too late. Early, it will be cyclic monthly pain, which means a child of about 14, 15, 16 years who is not menstruating but has got cyclic monthly pain and cramps, suspect cryptomenorrhea, suspect imperforate hymen, suspect vaginal septum, suspect stenosis of the cervix, because she's bleeding inside there and this blood is distending the uterus and is becoming painful. And as time goes on, that blood might flow backwards through the tube and irritate and cause endometriosis. This is the picture of an imperforate hymen. A normal hymen should have at least one hole. But if it's totally closed, imperforate, the blood will be trapped behind there. Firstly, it will accumulate inside the vagina until it accumulates inside the uterus. If it's accumulated inside the uterus, it's called hematometra. If it accumulates inside the vagina, it's called hematocolpos. You'll have hematometra, hematocolpos. Another cause of cryptomenorrhea is atresia of the vagina. If vagina is too small and it's just obliterated, there's no vaginal canal, but the endometrium is there. The endometrium will be released, and it won't have an outflow tract to pass through, because I said in order for a person to menstruate, she must have a patent outflow tract, which patent genital outflow tract. Or again, a person can have transverse vaginal septum. I made vaginal atresia in red because if that's the condition, the treatment is very specialized and can be treated and have a pain. Transverse vaginal septum, will show it here, is a septum that cut across the vagina and divided into two, the upper vagina and the lower vagina, and the blood doesn't pass through that septum. Or sometimes the cervix itself, which is very common, can be stenosed, they're not allowing blood to come out. This is a picture of drawings, not a drawing of an imperforate hymen in a young girl. But if we take a picture earlier on, it will just be, if you look at the child, that's why I say it's the duty of the mothers to look at their children, whether the hymen is perforated or not. If it's imperforate, then look for help before it causes hematometra, hematocolpos. As this cryptomenorrhea will present with absence of menstruation, which is not actually absence of menstruation. There is menstruation, but it's hidden menstruation and periodic pain on the lower abdomen, which is due to distension of the uterus and the vagina by that blood, and again due to backward flow of the blood through the tubes, which is for retrograde menstruation, and stimulating the peritoneum and the pelvis. And as time goes on, as blood accumulates, there'll be a swelling, suprapubic swelling, like a full bladder, like a pregnancy, which can even pull the urethra and cause urinary retention. Majority of children at that age, every month, she will be absent from school because of these menstrual-like pains, which makes her very sick. But she's not menstruating. She doesn't have pelvic inflammatory disease. She's not actually active, but she's lying in bed. It's like she can die. It's because of blood that's accumulating inside there. If a child has got such and is not menstruating, don't suspect pelvic inflammatory disease. Suspect cryptomenorrhea. And this can be treated. But if left for a long time, she will develop a bulge in the abdomen. And that's where mothers start to suspect foul play. They suspect somebody, the uncle or anybody, the child is pregnant. They think he's pregnant. He's not pregnant. That uterus is distended by blood that's been accumulating there. And in this picture, you see she's got a catheter because now she has got urinary retention, which is a bit late to see it if it's like this, because chances are that if cryptomenorrhea goes up to that level, it might injure the fallopian tube, and later the child will have a problem in having pregnancy. So imperforate hymen is what every woman who is looking after a girl child should look at, as the treatment is very easy. It doesn't need anesthesia. You just go in, the doctor will go under local anesthesia, make a hymen open in there, drain the blood that's already there, which will be altered blood because it's all blood, and leave a hole there. Then subsequent menstruation will come out, will become ovate, will not be hidden anymore. The second transverse vaginal septum is very common but difficult to diagnose. You can diagnose it only with experience, because these children, Mendo, they are virgins. So there's no direct access to the vaginal canal. But if they are virgins and there's no, the hymen is perforated, if there's no imperforate hymen, you suspect obstructions high up. If on ultrasound you can see blood accumulation inside the uterus or upper vagina, which is hematometra or hematocorpus. And the septums can take different form. Can be low down near the hymen, can be high up in the middle, can be high near the cervix, depending where it is. But the type of blood accumulation on ultrasound will give a clue where it is. Or it can be several septums, which depends on embryologically when the vagina was formed, which portion was formed, how, and what abnormality developed. Like in this woman who has got didelphys uterus, the uterus has got two horns. So she has got one septum going this way, which belongs to the vagina, that belongs to this horn, and the other septum down here, which belongs to this one. It takes different forms. It needs investigation to make a proper diagnosis in order to treat according to the malformation that is being formed. The cervix, a child might be born with a cervix which is not perforated or which is stenosed, and it traps blood inside it. A cervix normally should have a canal that the blood can come out of the uterus into the vagina and outside. If it gets stenosed in children, we suspect it's congenital, because this child might not have had sexually transmitted infections that will cause cervical stenosis. And if it's TB, as I said, TB can cause. TB will not target the cervix alone. It will target everything in here. She will have the whole uterus, the fallopian tube, the ovary will be targeted by tuberculous organism. So these three types of cryptomenorrhea, transverse cervical septum, you treat it by excision of that septum under general anesthesia. Stenosis is dilatation of the cervix. Do no curettage, dilatation alone. Imperforate hymen, of course, I've said, you do a cruciate incision on the abdomen, this one doesn't need anesthesia, and drain that blood and make sure that it remains open. The subsequent menstruation, blood will come down, except when parents should not wait until too late they see a bulging abdomen. If it's bulging abdomen, must know that the whole uterus is full of old blood. The whole vagina is full of old blood. That's why the hymen is bulging. And this old blood might go retrogradely and cause endometriosis, which will give the child infertility as time goes on. And hematometra is very easy to diagnose by ultrasound by seeing a fluid-filled blood below the bladder. This is the urinary bladder. Below it in the uterus, you know there's no other fluid that can be there except blood that we want it to come. And you look at the child, find the bulging hymen, which is not perforated. Then you make a diagnosis that this is cryptomenorrhea due to imperforate hymen. And of note is that if the vagina and the uterus during cryptomenorrhea, the vagina can dilate far much bigger than the uterus can because the uterus is more muscular. It refuses dilatation. You find that the mass in the vagina is much bigger than the one in the uterus, but the hymen doesn't perforate. It very does it best. This pressure in here will not best the hymen. The hymen is very strong. So the best thing is to treat imperforate hymen is to manually, under local anesthesia, drain that. It drains itself and it never really closes itself. To avoid blood accumulating inside the uterus and start to track back through the fallopian tube and trickle inside into the endometrium and causing endometriosis, which I said is one of the worst causes of infertility later. Because when we want the child to menstruate, we want him also when he's old to be able to have children. So delay in treating the menstrual disorder might cause infertility later in life. So if cryptomenorrhea is not a problem in a child who's not menstruating, then you look at the hormones. Are they functioning normally? And we have got 4 categories of patients who are not menstruating with poor sex characteristics. They are not menstruating, the breast is underdeveloped or is not there, the pubic hair is scary, scanty, or is not there, there are no axillary hair, or if they are there, they are just few. Or a patient is not menstruating, a girl is not menstruating with normal secondary sex character, with normal breast, normal pubic hair, normal axillary hair. Or a patient who is not menstruating with signs of androgen excess. What do I mean? With signs of male hormone excess. Androgens are male hormones. That person with androgen male hormones can either not virilize. Virilization, I mean, she will have features of male. She will have a coarse voice. She will have a clitoris, which is enlarged, like this, towards the penis. She will have beards on the chin, and she can have hair on the chest. And the pubic hair distribution will be like that of a man, which is like a rhomboid. You know, pubic hair distribution of a female is like inverted triangle. The hair never goes towards the umbilicus. But in this case, the pubic hair will go towards the umbilicus, like in male. Or the 4th category, which is the worst, which you don't wish anybody because very few people will do anything about it. It's a person who doesn't menstruate and he doesn't have a uterus, he doesn't have a vagina, it's congenital abnormal. Those are the people. Of these 3, the ones that are more commonly seen are number 1 and number 2. The amenorrhea with sign of androgen excess without virilization. If there's no virilization, the many women have got beards out here, but then they are menstruating normally and they can bear children. It's only problem when they are virilizing. They have got beards, but then they've got coarse voices, they are balding, they've got features of male. But if it's just only beards, it's just a hypertrichosis or hirsutism, which doesn't give much problem as far as menstruation and fertility is concerned. In such cases, both of this, firstly, we look at the hormones, the chromosomes. The study of chromosomes is called karyotype. If the chromosomal pattern is there's got 46 XY chromosomes, that child. This is a male genotype, male chromosomal pattern. The female, as said, is 46XX. If she has got 46XY, and she's a female, you look at her, she's a female, she's been given a male female because the genitals looks like females, because we rear children the gender by looking at the genital. Once a child is born, they look at the genital and say a male or a female. So genitals look like female, but the genotype, the genes, she's a male. Then is a condition called gonadal regression. During embryology, when the gonads developed, they regressed and they didn't respond to testicular factor that makes the gonads to develop into a male. Then they took the female root and become root, or they can be testicular enzyme deficiency, which is the enzyme that was responsible for transforming the gonads to be like male, to form testis and scrotum. Then this what was supposed to be a scrotum become the labia majora. What was supposed to be a penis become the clitoris. Or there's once inside the testis, there are type of cells that produce hormone, which are called Leydig cells. This is called Leydig cell agenesis. Leydig cells are not formed. If Leydig cells are not formed, then let me look who is talking here. Okay. Honor click, please do not. Then okay, I've removed him. If the Leydig cells are not formed, that person will not menstruate because the genotypically she's a male. She's got male chromosomes. She should have been a male, but she's developed physically into a female figure. So we give her a female name, we rear her as a female. And that person will have absent breast and absent sexual hairs. Then you can see that this person that we should look at the karyotype. Or the common that I've seen in my practice is people who are reared as girls. They come as girls, they put dresses. But to do karyotype, it says the chromosome pattern is male. They've got a condition called androgen insensitivity syndrome. Androgen insensitivity syndrome, I have seen more than 10 in my practice, and 2 of them I've treated successfully. But although in them you don't promise fertility, another name for androgen insensitivity syndrome is testicular feminization syndrome. These children come with normal breast, but they've got absent sexual hairs. They don't have pubic hairs and axillary hairs. Or if you do karyotype, you find that they are females and they are not menstruating. Suspect one of the things, Mullerian agenesis. You know, in the development of the gonads, of the sexual organs, the females, uterus, the vagina, the fallopian tube, they develop from the system called Mullerian system, while the males develop from the males are testes, the penis, they develop from the system called Wolffian system. If the Mullerian system has not developed, is agenetic, then a woman will have no uterus. Sometimes she might have part of the vagina absence because vagina is formed from 2 embryologic origin. And that condition is called Major-Rokitansky-Kuster-Hauser syndrome. It's just abbreviated as MRKH, but that means Major-Rokitansky-Kuster-Hauser syndrome. This is named after people who describe this condition. And these women, they can fool you because karyotype, the chromosome are females. They've got normal breasts. But of note, the secondary sex characteristic sexual hairs will not be so dense. Not all of them will have dense of them. Some will have absent sexual hairs. Some will have very few sexual hairs. But the breast development becomes totally normal. So it can fool you. An examination exclude major Rokitansky-Gaster-Hauser syndrome. This is a picture of chromosome pattern of a human being. I said study of chromosomes called karyotype. Every person has got 46 chromosomes. Of this, 23 is contributed by the father, 23 by the mother during fertilization. And if it's a male, it's going to have this last chromosome pattern, XY. If it's a female, it would be XX. And you can study these chromosomes to see what kind of chromosomes are they. That is a karyotype of a human being. I think I thought at this stage that in order when I talk about these abnormalities, just to give you briefly about embryology, the formation of the genitals. You know, the formation embryology of the vagina have got dual origin from two places. The Mullerian duct, which I said that the Mullerian system formed the female genital system, form the upper 2/3 of the vagina. And the lower 1/3 of the vagina is formed from the urogenital sinus, which is formed by the urogenital bulb. These two structures, the urogenital bulb migrate upwards while the Mullerian duct migrate downwards so that they can meet somewhere on the lower third of the vagina and fuse. When they fuse, they form a condition called vaginal plate, which later vaginal plate will canalize to form a vaginal canal at about 16, 17, 18, 19, 20 weeks of intrauterine life during pregnancy. This plate that originally separated the vagina from the urogenital sinus, which is the lower third, and it degenerates and becomes a hymen, while the remainder, it forms the vagina. That's how a vagina is formed. The Mullerian duct migrate downwards, while the sinovaginal bulb migrate upwards towards the head to fuse to form a vaginal plate, which canalize. If vaginal plate canalize, it forms the vagina and the hymen. Incomplete canalization of that vaginal plate, that's what is going to cause transverse vaginal septum. And then if the Mullerian system, which was supposed to migrate downwards, is absent, only the sonovaginal bulb will form. It will form a shallow vagina because then form a condition called major Rokitansky-Gaster-Hauser syndrome, which makes a very shallow vagina, not good for any copulation. This is the picture that I thought everybody can understand. The upper part is the Mullerian system. The lower part is from a sonovaginal bulb. They fuse somewhere here to form this plate, which later canalized and leave only a hymen. If the red part is not formed due to some congenital abnormality, the lower part forms. It forms just a shallow vagina, which will not menstruate because the uterus is formed from the Mullerian system, and the Mullerian system has not developed. So developmental defect of the vagina usually is due to Mullerian abnormality, either agenesis or dysgenesis, or in perforate hymen, or in vaginal septum, or the upper third of the vagina, which becomes atresia, which is coming from the Mullerian system, which complete absence of the vagina is very rare, but theoretically is there, where the Mullerian and the sinovaginal bulbs might not develop. But if there's a shallow vagina there, I suspect major Rokitansky-Gaster-Hauser syndrome. I've got a condition that I'll show you, which I did of major Rokitansky-Gaster-Hauser syndrome. This is a patient that came to me some years back. Primary amenorrhea. She was already 17 years, brought by parents. I saw a shallow vagina, and the ultrasound, I couldn't see any uterus. Then I did a laparoscope. This is a laparoscopic view. What you see also there is the bladder, is the catheter inside the bladder. I saw she's got urinary bladder. She had ovaries. You can see there she's got ovaries with hydrated cyst of Mogani there. She had fallopian tubes. The white things, they are ovaries. But in the middle, I should be seeing a uterus. There's no uterus. There's not even a streak of a uterus. Then I suspect this woman has a developmental defect of the Mullerian systems. Both ovaries were there, the left and right, and the fallopian tubes were there. This is the left ovary. She has got major Rokitansky-Gaster-Hauser syndrome. Then my problem was to explain to the parents that this is a child, she does not develop a uterus. When she can't menstruate, she won't be pregnant. And because she was already 17, even herself, I need to counsel her and tell her what, so that she can live with that condition. But they said she has already, age mates have had quite hard. They're starting to be date boys. This is the finger in the vagina, which is shallow. They start to date. Now, they're worried that once she have a boyfriend or get married, because children are not just necessary, it's not a condition sine qua non for life, but you need to have a male partner. So we had to devise means that we can make a vagina for her, but that vagina will just be for copulation. It should not be for reproduction. So she agreed. And subsequently after this one, we did more. Doing creation of vagina is it did multidisciplinary approach. I had a very good surgeon from Pretoria University, Henny Berger, who would give me an intestine and I could make a vagina with that. But I assured them that that will not be for reproduction. So a patient with uterovaginal agenesis, which is major Stanley-Gaster-Hauser syndrome, will look like a female. Look at the pubic the breast, and everything is just curves, beautiful female, but she has never menstruated in her life. She's got normal sexual hair development, normal breast, normal looking external female genitalia. And if you take hormones, they are normal. The female hormones are normal. Even testosterone is a normal female range. But if you examine, like you have seen in the previous video, she's got no upper vagina, she's got lower vagina, and the karyotype of the chromosome is female. She might have other abnormalities of the kidney, of the renal system, because the renal and the genital system during embryology, they develop from the same area lateral to the notochord on the dorsal aspect of the embryo. So the abnormality of the genital system usually have got abnormality of the renal system. So these women, they are sterile. They cannot menstruate. Even if you do dilatation of that shallow vagina, it won't be as deep enough to can do anything. But the treatment is creation of the vagina. Christina, wait, my dear, don't write here. I'm saying this and stressing it because I need to stress it because many women will be sitting with children with major Rokitansky-Gaster-Hauser syndrome, but will not know what to do because these children look normal. This disorder, it is a disorder that causes the vagina and the uterus to be underdeveloped or absent. Without a uterus, these women will not have menstrual period, of course. You need a uterus to have menstrual period. So because they don't have uterus, they don't menstruate. Often, the first notable sign of major Stanley-Gaster-Hauser syndrome is when a child does not menstruate by the age of 14, which I said the cutoff limit. In that one, we managed to do this, showing how to create a vagina for her. We took the intestine. The general surgeon, Berger, gave me a piece of intestine from the same baby. While she's harvesting the intestine, she looked for the area of the large intestine with good blood vessels so that the vagina that's created can have good blood vessels. And then give me about 12 centimeters of that vagina so that I can create a vagina with this intestine, which I take together with this blood supply and implant into the area that would have prepared for the vagina to come. This is the anastomosis of the area where he took the vagina from. From there, we prepare between the bladder on the posterior aspect of what we've seen as a streak where the uterus are supposed to be. We create a channel there, and this is the finger, my finger from above. And we take this intestine through here, and the other side we close it, becomes a cul-de-sac. We take the intestine through here and suture it around. But when you suture, you make it vice versa so that peristalsis must go backwards. Otherwise, the intestines has got a lot of mucus. She will just keep on having mucus. And suture it here and form a vagina which can have sex with, but she cannot menstruate, this child. If patient has got primary amenorrhea without secondary sex characteristic, we set FSH level, which follicle stimulating hormone produced by the pituitary, are low or normal, you must know is hypogonadotropic hypogonadism, which I described earlier. If FSH is high, suspect gonadal dysgenesis like major Rokitansky-Kawsar-Hauser syndrome, which will be confirmed by other congenital abnormalities that you would have seen. If you look at this one as hypogonadotropics, you'll have infantile secondary characteristics. The labia will be infantile. And if she's hypergonadotropic, got high gonadotropic, you suspect that it's ovaries that are failing, or the ovary are just resistant to stimulation by pituitary hormone, or it's just got a condition called 17-hydroxylase deficiency, which is part of congenital adrenal hyperplasia, which is a endocrinological condition of the adrenal gland. Then, if this woman has got normal height, normal external internal organs, but the gonadotrophins are low, then you suspect this woman, you do an MRI to rule out pathology in the head. It's either the problem is in the pituitary or in the hypothalamus, because the height is normal. Although they can fool you, because people with constitutional delay will also behave like that, because secondary sex characteristics are the same. You treat according to the cause from the history, but firstly you wait. I would suggest that you wait until it was 16 years and see. But if gonadotropin are low, you don't suspect constitutional delay. You stimulate her with pulsatile activation of gonadotropin releasing hormone, and you assess the hypothalamic pituitary ovarian axis dysfunction. Exclude things like stress. Stress in children can be there. In families these days, stress can be very much in children. A children who from poor family can be stressed by not having shoes while other children at school have got shoes. They can be stressed by familial issues. They can be stressed at how they look. Maybe she's got some looks that don't look. It's got a big forehead, and other children are teasing her. Can be stressed by many things. Excessive exercise, not exercise for gym. Children who walk long distance, running, going to school, they cannot menstruate. And children who has got a psychological condition called anorexia nervosa and bulimia, which is psychiatric condition, which will not go into much, will need psychiatric evaluation. There are children who have got inadequate production of gonadotropin release hormone by the hypothalamus. And these children are known by having absence of, they've got anosmia. They can't smell anything. They can't smell perfume. They can't smell flavors. They can't smell anything. They don't smell. This Kallmann syndrome. Kallmann syndrome is very rare. It's an inherited disorder characterized by delayed puberty and impaired sense of smell. They can't anosmia. They can't smell anything due to lack of this gonadotropin releasing hormone, which is produced by the hypothalamus in the brain. And this usually, these people are who are hypogonadotropic hypogonadism. Of course, tumors of the brains will give you the same, especially craniopharyngioma and prolactinoma, which are very rare in children, but must also be put at the back of the mind. Most prolactinomas, which are tumors of the pituitary, which can be seen either by MRI or cone down view of Salatusica, and can produce prolactin. If they produce prolactin was suspected by breast that's secreting in a young child, milk secreted in a young child, then you know that I'm dealing with the intracranial pathology. If the gonads do not develop, there are other syndromes and classical conditions that must be put at the back of the mind, although very rare, but they do occur. One of them is Turner syndrome. It's a chromosomal abnormality where instead of having 46 chromosomes, a person has got 45 chromosomes and is a female. Or it can have a variant of Turner where there's a mosaicism. Mosaicism means two sets of chromosomes in one individual, which in some cells have got 45 X chromosome. The other X is not there. And some cells a full complement of chorocyte of 46 X chromosome. In other, one chromosome is absent. It's a Turner syndrome, but variant. Or a patient can have mixed gonadal dysgenesis. She's got 45 X chromosome, which is a female, and another chromosome set is 46 XY, is male and female, it's mixed in one person. And phenotypically, external appearance, she appear like a female, but she has got a component of chromosome, which are male chromosomes inside here. Or if they are chromosomally competent, she's got 46XX, then that one we know that is pure gonadal dysgenesis. If it's 46XY, but looks like a female, like she has had a mosaicism, is a condition called Swyer syndrome. And Swyer syndrome must be distinguished clearly from testicular feminization syndrome because they look more or less the same, except the things that are delineate. Swyer syndrome, although is very rare, is a genetic condition affecting sexual development. A person has got female external genitalia and female identity, but she has got XY chromosomes. She's got male chromosome. She doesn't have functioning ovaries, while testicular feminization syndrome has got testes. We know that it is a female with testes. This one doesn't have ovaries or testes, no gonads at all. She doesn't have male gonads, she doesn't have female gonads. While testicular feminization syndrome, which is androgen insensitivity syndrome, has got antecentered testes. We'll show it later. Instead of gonads, this individual with Swyer syndrome, they'll have underdeveloped straight gonads. Somewhere there you see there was supposed to be a gonad, but it's just a remnant. And these symptoms appear usually during adolescent as primary amenorrhea and lack of pubertal development. While in testicular feminization, there's breast development, although there's no secondary sex hair development like pubic hair and axillary hair. This is a typical person with Turner syndrome, which every many can see. They have got this characteristic. At the neck, you see she has got a webbed neck. And if you look at the back, at the occiput, the hairline is low. And she has got increased carrying angle. If she takes the arms on the side of the body with the palm facing downwards, sorry, the angle here is increased about 15 degrees carrying angle, while a normal person has got about 3 to 4 degrees carrying angle. So got increased carrying angle. But phenotypically, she looks like a female, except that the genotype, she's got 45 chromosomes in them, and they're sterile. They do not bear children. This is Turner syndrome. It's got 45 XO. Well, the one that I said is pure gonadal dysgenesis will be a normal female genotype or partial deletion of one chromosome, which is not completely deleted, will be partial Turner. They are females with 3 gonads. I said that I want to talk clearly with a condition which I've seen many times and studied many times, and they usually come late, which is androgen insensitivity syndrome. Another name for it is called testicular feminization syndrome. These people, they are genetically males. These girls, what do I do? I say these girls are genetically males because they are reared like girls. They've got external genitalia that looks like girls, but genetically they are males. They are male. They were not supposed to be like that. So you look at them, they've got hefty bodies with breasts that looks like men, but they are females. We read them as females. So this slide shouldn't have come here. This describes to you what Turner syndrome is like. The associated features that you must see in Turner syndrome is increased carrying angle, cubitus valgus, which the carrying angle if is increased, the widely spaced nipple, broad-based chest, and if they've got congenital abnormality, will be like coagulation of aorta. Of the karyotype, you will find 45XO, and this is Turner syndrome. You see the carrying angle is increased, but they are females. This is typical Turner syndrome. This is mosaic. This mosaic means just got two sets of chromosomes. Other cells have got normal 46X, and other cells have got 46XO. It's Turner syndrome, which everybody can see it. The principle of management of these children with amenorrhea is to restore ovulation and menstruation. If not possible, you have to give external hormone replacement therapy in the form of estrogen or progesterone to induce that ovulation and to induce development of secondary sex characters like breast development. Usually, periodic progesterone will be taken in patients who are amenorrheic but they've got normal estrogen, they are estrogenic. If they are male genetically, they've got a Y chromosome, the usually majority of them might develop testes, which becomes undescended testes. And they'll require that you remove those testes because testes, if they are undescended, they are subject to the high temperature inside the body. Those are the testes that develop germ cell tumors, gonadoblastomas, cancers. So you must remove them after puberty. If they're not like that, they're not removed, she'll have that. So in summary, not in conclusion, if a person has got absent vagina, like major Rubitansky cancer houses, do vaginoplasty, make a vagina before marriage, before she can even court with boys. If she's got Turner syndrome, give replacement with estrogen and progesterone so that you can encourage pubertal development, you can encourage breast development and secondary hair development. If a woman has got testicular feminization syndrome, which I said is androgen insensitivity, I said they are genetically males, but they look female. And they'll have testes, which is undescended. If they are undescended, they are inside somewhere in the body, and they develop cancers called dysgeminomas or related cell tumors, which can be lethal. So they must be removed immediately after puberty. This testicular feminization syndrome is called androgen sensitivity. They are read as females because when a child is born, we look at the genital, well, it says female. And once you assign a certain gender to a child, once he grows up with that gender, you can't change it. Otherwise, you confuse us psychologically. They've got undescended testes. You remove them and give them exogenous conjugated equine estrogen to maintain those sexual characteristics. But all these conditions that I've mentioned here, there's no prospect of fertility. But fertility is not all that's needed. I want to explain why the testes of any male, whether it's a man or it's a donkey or it's a dog or anything, are outside because testes develop better at a temperature lower than body temperature. If these testes of a cow have to be inside the body, they will be at the body temperature of a cow and they'll develop tumors. So is a man also. Testes must be outside. That's why it's not advisable for men to put on tight underclothings. If they've got tight underclothing, these are men that has got low sperm count. Nowadays, I see rich men, they've got cars that can heat. They say my car can heat, the seats can heat. Those seats, if you sit on a heated seat for a long time, you're increasing the temperature of the testes, you might end up not being able to make children. That's why all animals, the testes are outside because they need to function at a temperature lower than that. If they are undescended, they'll be somewhere inside the body and they will be subject to the temperature of the body. That's why removal of that undescended testes immediately after puberty at about 11, 12, 13 years must be removed because if it can reach 20, 25 years, she will develop that. A condition that I have treated many times, and the last one that I treated, I recorded it. I just want to share with you, is a woman who came with good breast development, no, absent secondary hair, no pubic hairs, no axillary hair. This is a condition who had androgen insensitivity syndrome, which is called testicular feminization syndrome. They look, if you look at them, they are beautiful. They look like female. And we rear them as female. Because on the cytoplasm of the cell, they've got receptors for androgens. That's why it's called androgen insensitivity. So if it doesn't respond to androgen, it develops along the male line, which I want to say it unscientifically. Every human being is developed being a female. It's only the presence of androgen and androgen receptor that makes males develop out of that route of becoming a female. That's simplistic to explain it like that. They have got normal breasts, but no sexual hairs. And then they've got normal looking female external genitalia, except that the vagina is shallow. They've got absent upper vagina, but the lower vagina is there and is shallow. The karyotype, if you look at these chromosomes, the 46XY is a male karyotype, it's a man. The range of testosterone, it's in the male range, is very high. And they develop undescended testes because they've got no cytosol receptor to testosterone. They don't develop virilization. They don't develop BS. They don't develop cause voice because the cytoplasm can't respond to testosterone level, which is very high. So the treatment is removal of the gonads, removal of those undescended testes. And after removing the undescended testes, then you can be hormone replacement therapy. And if she wants to have a good relationship with the opposite sex, you either do vaginal dilatation or you dilate that shallow vagina, or you do vaginal creation like we have seen creating like that. I want to show you this patient I did somewhere in March this year in Mankwe. It's a woman who was already 19 years old, Amenorrhoea, and we determined by karyotype that she's a male. And it was very difficult, and we look like we are mad when he says a male, what she's a female. But we explained to her that she has got testicular feminization syndrome, which is more common now. We see it more common, where a person with male genetic makeup cannot respond to male hormones because of lack of cytosol on the cytoplasm, leading to taking the path of development towards the female, besides having testes. They've got female appearance, but they're genetically males and they're infertile. So I did this. I was the surgeon. We had to go and do gonadectomy because she has already passed the 16-year mark. She was 19 years. And when you look at laparoscopy, the first thing you follow the path of the ovarian vessel. The ovarian vessel will go outside, will exit through the internal inguinal ring because the testis here could be palpated inguinally outside when you examine. But you don't want to do laparotomy to remove it. I said I'm going to remove it laparoscopically just because I'm just keen laparoscopy. I'm just a keen laparoscopic surgery. I could have as well have done laparotomy, but I decided I'm going to do minimal invasive surgery, which will take me much longer, but it satisfies me a lot. And you trace the anal sac until you find a testis. That's the testis coming out. And with that testis, I took it out, both sides, one testis on one side and testis on the other side. And then after removal of the testis, what remained there was a inguinal hernia, which I repaired laparoscopically with a mesh. And the patient, when I was seen her 8 weeks thereafter, she was well and well counseled. I sent her, of course, for psychological counseling more so that she can accept that she must be reared as a female because the name is female and she plays with females, but genetically she's a male and she will not change her sex. There's no need for sex changes here. So the woman is living all right here in Polokwane and she's fine. And so with this, after removal of this testis, we cut it and then put it on conjugated equine estrogen. I like using endoloop to tie it up because the ovarian vessel that supplies this testis, I call it ovarian vessel because it's a female. Actually, it's a testicular vessel because in a male it's testicular vessel. Can bleed very well if not well tied. After removal of the testis, after I've tied it, you need to remove it completely because you don't want to have these tumors like this geminoma, yolk sac tumor, or gonadoblastoma. Very rarely you can even have choriocarcinomas in here. This is a picture of gonadoblastoma, which is a tumor of the testis, which develop in the undescended testis, which must be removed early. And after tying it, I like using, you can use meds, you can use argon beam coagulator, you can use a laser, you can use a laparoscopic scissor. I like using electrocautery. This is a bipolar electrocautery which bends and cut. So I cut the testes with the electrocautery. And the advantage with electrocautery is that if there's bleeding, I can coagulate and stop the bleeding. Like I'm seeing here, I'm coagulating and stop the bleeding. But with others, you have to change to electrocautery. Removed it altogether and give the woman or the girl conjugated equine estrogen to maintain the presence of those breasts and the voice that becomes like a girl. She shouldn't virilize and have a coarse voice like me. And the testes remove both sides, one side and the other side, the inguinal hernia get repaired. Because it is a big inguinal hernia, we had to use a mesh, but it was also done laparoscopically, which was successful very well and peritonealized. And she presented after 8 weeks with no residual symptoms, only few laparoscopic scars. And after removing the testis, if you cut it, you must remove it immediately. This is the principle of laparoscopy. If you don't remove it immediately, you might lose it inside here. It might be somewhere inside the intestines, and people have spent, you see, now the two sides of the testis are now removed. And then with an endobag, I remove. People have spent hours looking for a tissue that's inside the body that got lost. My principle is that once I remove it, I put it inside the endobag, I take it out because I don't want to lose it inside the intestine. As you ask the anesthetist to do Trendelenburg and anti-Trendelenburg, the tissue might move somewhere where it just get lost. This is the woman that's alive. If a person has got testicular feminization syndrome, consult the parents properly and the patient properly and remove the gonads because those gonads are not ovaries, they are the testes because she's got testes. Another condition which can be seen is children who have got hypophyseal pituitary ovarian axis defect who present with mental retardation and craniofacial deformation. They are usually due to thyroid hormone problem. They are hypothyroid, infantile hypothyroidism. Hypothyroidism in children will give you a condition called cretinism. And the cretins, they're short statures, mentally retarded, craniofacial dysmorphia, and they've got amenorrhea. And then those who have got androgenital syndrome will have excessive androgen, and the clitoris will grow larger as if it's a penis. That's virilization. The treatment will be steroid and maybe lateroplasty if you've got a condition to do that. Cretins, or the condition called cretinism, they present physically, you can just see this child doesn't look quite normal. It's got on the face and the cranium, there's abnormalities, a physical development. The deficiency of thyroid hormone in children, that's caused that. And it's got some intellectual impairment and small stature. So if a child is like that, clinically you can just see it. The other conditions that hypophyseal pituitary ovarian axis, besides cretinism, if they've got increased androgens, if you look at the genitals, they can be ambiguous genitalia. You don't know whether it's male or it's a female. The child has got ambiguous genitalia because the clitoris, because of increase in androgen levels, testosterone, it enlarges. The labia, because of increased androgen levels, they become labioscrotal folds. You know what is scrota? The only way you can differentiate whether it's a male or a female, you do karyotype and look at the hormones. What hormone level does he have? If a child has got none of those conditions mentioned, TB test, and it doesn't have a stress. Look, but she has got a breast secretion, suspect pituitary problem, do MRI or count down view of the salatusica to make sure that this child doesn't have pituitary tumor, because pituitary tumor can present as headaches to the baby or visual impairment, usually bilateral hemianopia. She can't see much on the side because the pituitary, where it's seated, is seated just below where the optic chiasma is passing above the area of the brain, which is called salatusica. So it can compress the optic nerve there and cause visual impairment. Although in summary, ladies and gentlemen, the workup of amenorrhea may seems to be complex, but with experience, carefully examination, you can exclude many of the things, like cretinism, you can include it. And looking at the patient's hormonal profile, you can exclude others and remain with few that will need invasive investigation and make a proper diagnosis. What I'm saying the diagnosis might not made in one consultation. It might have to require several investigations by the same person. So parents tend to do doctor shopping. They go to doctor one, he does FSH, and let's see what it is. They say, that one is guessing. Why is it this and this? You cannot, it's complex. You must exclude other things because phenotypically, clinically, they present more or less the same, except few like Major-Rokitansky Custer-House syndrome. Even a condition like a testicular feminization syndrome, it looks more or less like Swyer syndrome. Like Swyer syndrome doesn't have gonads, but this one has got gonads. So you have to do karyotype first and even do laparoscopy to make sure that, well, are you dealing with androgen insensitivity syndrome or you are dealing with Swyer syndrome? Management of this is restoring the ovarian cycle and menstruation. Fertility guarantee is not something, is beyond the scope of this webinar. So our take-home message is that any child with primary amenorrhea who has never menstruated, absence of period at 14 years, parents must take steps to make sure that is there something not abnormal here that need to be addressed now or not. It's not wise to adopt a wait-and-see attitude. Thank you very much for your attention, ladies and gentlemen. You can open your... Should I allow you to open? I think you can open. Let me see. How do I... Unmute yourself, and if you can ask questions or comment, this is the time that we can do. Can you hear yourself? Let me do like this. Nagari, unmute yourself. I want to unmute you, but I always bias. I don't know where to unmute you. But you can unmute yourself. If you want to unmute, you can raise up your hand. And if you raise your hand, I can see you here. Then you can comment or ask questions, clarifications. Tselale, I see you are unmuted. Dr. Makoti, I see you are unmuted. Uyan. It seems like they are not. Uyan mtokwa. Tokomela vana va tole va kata le vana va sa ikgwedila nana le lebelela ano dula ra ba to hola ba to kwana kwe tota ya ba le gore bothata bo ntse bo ya hare nya ka gore batswadi ba lebelle e bona ngwana se tsa fitlile 13 14 years le mo sepetse I want one of the doctors here. Dr. Makoti, how are you?
I'm fine and you, Doc. Very, very good and interesting presentation. Can you hear me?
I can hear you, my friend.
Yes, so really it makes one think of reading a lot. And I think, the other day you presented the topic on transgender. I think maybe if we had this before, it would be easy for us to comment on that one and to have questions on that one. But really, it has opened up my mind, and I won't. I'm not going to continue just discouraging people for sex change or whatever. Thank you very much, Dr. Mahapa.
Thank you. Because you, as a general practitioner, you are the first one to meet these conditions, and it's important that you should look and get because here you are not treating only the child, you treat also the parents psychologically, because every parent is ambitious about the future, reproductive future of his child. Okay, thank you, Minier. The next one, do you know how to raise your hands? I don't know.
Dr. Mahapa, Monokwani.
Oh, I've got my friend Professor Monokwani here.
Yeah.
I must give you a brief review of Professor Monokwani. Professor Monokwani ke bokgonyana wa leboa. O nyetše maešomo ke sebara. So, but as a professor in gynecology, he's living in Pretoria.
Yeah, just a quick one, Dr. Mahapa. Thank you for this important topic. I think for many people who haven't really delved much into obstetrics or gynae may not have understood some of the things, but as the previous speaker said. However, I think what you emphasized is the general approach or an important approach. A child hasn't menstruated by the age of 14 with normal sexual characteristics, or has gone to 16 and hasn't menstruated, irrespective, must be investigated. Number two, always, you're quite right, we need to exclude, make sure there's no pregnancy, but important is the proper examination of the child. And you've alluded to some of the conditions where the uterus is full of blood, hematometra, cryptomenorrhea, and so forth, that in the examination, we will be able to pick up. And I support you because recently I had a child who had been to various hospitals and they missed just a simple thing, that the child has got transverse vaginal septum. So the important thing is clinical examination, look at the hymen, is it intact, is it perforated? Quickly check by palpating, is the uterus enlarged or not? If it's enlarged, you already know either there's a transverse vaginal septum or cervical stenosis. And I think you've outlined all those things. So important is clinical examination. When it comes to the workup, to emphasize exactly what you said, FSH, LH, one should add prolactin for those who have hyperprolactinemia, and thirdly, or rather, testosterone as well. Now, the issue of testosterone will help us in two aspects. PCOS generally gives us secondary amenorrhea. However, you may have these young girls with PCOS from early on and have prolonged amenorrhea. So when we have done all those tests, including our testosterone, we know. Now, I just wanted to add another condition where you have ovotesticular intersex stage. There was a professor of obs and gynae, many in the 60s, Willie van Niekerk, and I think you'll remember him. He was briefly a minister of health in the old apartheid. And he did his PhD on ovotesticular, or on what he called hermaphroditism. And hermaphrodites are none other than where you have the genitalia confusing male and female. You have clitoromegaly, you have a canal, vaginal canal opening, though is blind, but they always have ovotesticular tissue. And I think as you went through various stages of management, that's very important, just the basic workup. And three is for us to say, general practitioners refer to gynecologists. Gynecologists don't tackle unless you have an interest like Dr. Mahapa so that at the end of the day, the patient benefits. We had a patient referred before you went to Mankweng, sent for vaginoplasty. However, on examination, I found that he's having breasts, but as you said, there's no pubic hair. Clinical examination showed very clearly she's a patient who's normal, but when you do the chromosomes stereotype, it showed that that's where they're abnormal. Nobody talked to this patient. They just said, oh, you don't have a vagina, go to Harankua for vaginoplasty. Secondly, to discuss with the family, how should she be raised? Is it a girl? Is it a boy? Who does she socialize with? And I had to do laparotomy, remove a remnant uterus, because everybody missed what is called, where she had cyclical persistent pain, but no menses, nothing, hypoplastic. However, it was reacting to the over-testicular tissue. So in conclusion, from my side is to say, brilliant lecture. Thank you for that. We need to continue highlighting these important topics so that we can help our young girls. And let's not forget, lastly, from my side, is always involve psychologists so that the child can adapt and be helped as we give hormonal replacement therapy. As Dr. Mahapa outlined, we need to assist to the psychological aspect. So thank you, Dr. Mahapa. Very good topic.
Thank you, Professor Monokwani. You made a very good addition, Salat, on top of that. As I said, this is a multidisciplinary approach. You've got to have psychology, the social worker, all other disciplines together, because as a doctor, actually doctors are very bad in counseling. They are very impatient. Counseling needs many sessions and approach. The psychologists are trained in approaching the situation so that people can accept this condition before you do treatment. Thank you very much, Dr. Professor Monokwani Zem. If I take the other question, it will be the last question. Dr. Makoti who works in Tembisa, commented. Professor Monokwani, who is an option gynae professor, commented. I want just Vasadi the ring, but Kavana, Ludisa Vana Bian. Numsadi Mario, Padio Ruja. Mana va se mensimerin dum durava no via no total mensa. What do you do, Joey? Yeah, how much Mukhadi? I know this woman. Mukhadi Araushah, get me this man. Mukhadi, this is a professional nurse. How do you raise children? Unmute and tell us. If you meet such a child as a nurse, what will happen? Hmm? He doesn't know how to unmute. Mukhadi doesn't know how to unmute. Okay. Okay, ladies and gentlemen, this is the little I had about this webinar. As usual, I do not promise the next webinar what it will be. It depends on my mood or what I will prepare. People will think because it's primary amenorrhea, the next webinar is secondary amenorrhea. No, it doesn't work like that. I just wake up one day and say, the next 2 months I'm going to do this, because my webinars are 2 monthly. Thank you very much, ladies and gentlemen. Till we see each other in the next webinar. Thank you.
Good night, Dr. Mahapa and colleagues.
Thank you, Dr. Mahapa.
Thank you, my dear.
Love you.
Thank
Nice
you.
presentation.
I'll see you again, my children. God bless.
I will see you again, Kumachichileng. Yes.
Yes, Ramolo.
Who is that?
This is Pukule.
Oh, Pukuwe. Oh, how are you?
Ay, Governor Ramolo, Ralebuha.